Our topic is physician-assisted death and mental health slash illness.
I'm Sky.
I'm Jenny.
I'm Erin.
And I'm Anava.
All right, what is physician-assisted death? I'm going to be using the abbreviation of PAD within this slide and throughout the presentation, just so you know. Overview of it. Um, Physician-assisted death provides the option of ending one's life through medical interventions. This treatment often includes lethal doses of medication, and it requires strict eligibility. PAD is important since it gives the patient agency over their own body and allows them to be at ease from physical or psychological pain. On a personal level, our group was interested in researching PAD since it expands across many different topics such as healthcare, legality, and ethics. I believe as nursing students, we must advocate for our patients and listen to their needs. This includes both physically and psychologically. However, with this topic, there are many complications that can impact the patient and their relatives and loved ones. After conducting research, we analyze the topic from multiple perspectives, which include cases globally, which just illustrates the widespread concern for patients. On a macro level, the topic is extremely relative to modern health since there's an increase of people suffering from unbearable mental illness and physical impairments. Sorry. Um, PAD can alleviate stress placed on the patient by shifting their plan of care from preservation of life to comforting end of life interventions. This treatment often involves doctors, nurses, social workers, and legal professionals. Additionally, this procedure requires a specific set of requirements that include state regulations, age, and mental eligibility. Health professionals must dictate who is a valid candidate and provide adequate patient education and support.
Okay, so currently in the world, wait. Okay, so the current status of physician-assisted death for mental health specifically, currently in the United States, it is illegal to provide physician-assisted death for anyone that is having a non-terminal illness, which means mental health patients are excluded from this criteria. Currently in Canada, they've been working to pass a law amending their criteria for physician-assisted death. However, this keeps getting pushed out yearly, and right now it's set to be reevaluated in 2027. Um, and then internationally in Europe, Austria, Belgium, Netherlands, and Spain are the only countries that allow physician-assisted death specifically for mental health patients.
Okay, so the criteria, it varies by state and by country. I included a link over here you can see from Compassion and Choices. It's a website that just shares a brief overview of all the different states breakdown. So the four main consistent points is that you must be an adult, so 18 years or older. You must be terminally ill with a prognosis of 6 months or less to live. You must be mentally capable of making your own healthcare decisions and able to ingest medication. Some of the differences is the number of signatures by physicians required by state. So, for example, in Washington, here we require two physicians with a 48-hour wait period. Um, but states like New Mexico, you only require one, and it's also a 48-hour wait period. And then also, some of the states have varying terms of terminally ill and unbearable pain. So, I know like some countries don't require you to be terminally ill. And then also the waiting period between requests can vary anywhere from like 16 to 48 hours.
Okay, so continuing off of what Jenny said, as we discussed, the criteria for physician-assisted death kind of varies depending on where we're looking. And the big difference is that in the United States, you're not allowed to, physician-assisted death is not available for anyone with a non-terminal illness. So when we're talking about mental health, we kind of have to look internationally. And a big leader in physician-assisted death for psychiatric illnesses is the Netherlands. So it's been legal since 2002. And the big criteria is basically that they don't differentiate between a non-terminal illness and a terminal illness. And they also don't really differentiate between physical suffering and mental suffering. So some stats from 2024 in the review from the RTE, there was 2.2% of all of the euthanasia cases in the Netherlands were due to psychiatric disorders. So it was 219 cases. And then other additional stats that were collected over a number of years found that 66% of cases, specifically with psychiatric disorders, reported that the primary reason for seeking euthanasia was social isolation and loneliness, and 24% of those people had at least one outside consultant that disagreed with the decision. And this just shows how controversial the topic is, because even though it is a criteria that they must consult someone outside, that's like a non-biased source, even when they disagree, they can still carry out the euthanasia. Okay, and then Belgium is another big leading country in euthanasia, and it's also been legal since 2002. And some examples of controversial cases where people were able to access euthanasia were in 2013, there were two deaf twins that were 45 years old, and they had a form of glaucoma, which was making them go blind. And they were able to get access to physician-assisted euthanasia, where they had a physician inject them with the lethal medication. And their main reasons that they supported this was saying that they didn't want to have to depend on other people. And this was controversial because many people said that going blind is not a terminal illness and not something that would be physical. Like, it doesn't cause as much no, we're gonna cut that out. I don't know what the other thing was. Okay. And then the second case that I have for you is in 2015, there was a 34-year-old woman who had chronic depression that also had access to euthanasia. And there's a PBS NewsHour little short documentary about euthanasia in Belgium, and they actually cover that case. So that is an interesting thing to look into if you're curious. And I have the information here. And I will say viewer discretion is advised because there are some pretty sensitive topics and like images and things like that. But it's an interesting read. Okay, and then coming back to the United States, like we had been discussing, it is not legal to have physician-assisted death for solely the purpose of mental health illnesses here. But we have had general physician-assisted death legal since 1994. And since then, we now have 12 states that have it legal. And the first state was actually Oregon, and I believe the second state was Washington. And an interesting thing to note is that the American Psychiatric Association actually opposes physician-assisted death altogether because there is concern that all the criteria is really subjective and it could lead to, they call it the slippery slope, where eventually mental health illnesses will become eligible as they have in other countries.
And then speaking towards this PAD and portrayal in media, it was first brought to the public's attention I found around 1870 when Samuel Williams first proposed using medical means to end an individual's life. And debates surrounding euthanasia and assisted suicide erupted and would stay relevant for decades to come. And then around 1906, there was a controversy that culminated surrounding an Ohio bill proposed to legalize euthanasia, which sparked an ethics debate within media and ultimately resulted in a defeated legislative effort, but it was something that stayed on people's minds. And then kind of a big media, a lot of media attention came in 1998 when a CBS 60-minute broadcast of pathologist Dr. Jack Kevorkian provided a lethal injection to a patient, Thomas Uke, who was suffering from ALS. And Kevorkian was referred to as Dr. Death, and he championed this assisted suicide as a form of medical treatment. But he was accused of manipulating popular media by including a shock factor. One such example was he harvested a kidney from a victim patient to offer for transplant, despite knowing that it would not be accepted as a viable organ. So many defenders of PAD and euthanasia noted his personality and methods led to a lot of pros and cons to be obscured from the reality of the procedure and kind of led from the truth of what they perceived as the benefits or the failures of the procedure. So where does this leave us in terms of surrounding discussions, debates, and controversies? While some argue for the legality of this procedure in preserving an individual's dignity, the journal that surrounded non-faith-based arguments against PAD offers a counterpoint of view. They basically argued that dignity rests not on the person's interests, but rather the values of the person whose interests they are. And the value of that individual is infinite. Essentially, they argue the productivity of a person, how others view that person, and how they view themselves does not matter when everybody, healthy or sick, is a somebody. So if we accept assisted suicide and euthanasia, then they say we're accepting it as a morally permissible circumstance to act with the intent to make somebody into a nobody. And ultimately, they state this truly takes away from the dignity of being human, for it is not the outcome, but rather the intent that is at the core of ethics and this ethical debate surrounding this procedure. So as far as global perspectives, Erin and Jenny kind of touched on Netherlands a little bit, but for the perspectives and how it differs to the United States, for this point of analysis, we use research and data from reliable medical journals, which utilized medical and legislative records to account for the stated information. And the author noted the absence of any commercial or financial relationships that could be classified as conflicts of interest. So within the Netherlands, PAD is possible for patients who have a well-considered death wish and who suffer from medical or psychiatric condition deemed unbearable or irredeemable. In the 1990s, there was the Shabbat case, which concluded PAD is allowed for somatic suffering and under detailed stipulations allowed for psychiatric suffering. So essentially, physicians must follow a criteria outlined within the Termination of Life on Request and Assisted Suicide Review Act. These 6 criteria are as follows. First, the physician must be satisfied that the patient's request is voluntary and well considered. The patient's suffering is unbearable and there's no prospect of improvement. The physician must inform the patient of his or her situation and further prognosis. both the physician and patient must discuss the situation and come to a mutual conclusion that there is no other solution. The physician must consult at least one other medical professional with no connection to the case, and they must meet with the patient and be satisfied with the latter four due criteria. And medical care and attention must be exercised in terms of the patient's life. Additionally, for psychiatric patients specifically, there needs to be a psychiatrist offering a second opinion, and they typically specialize in the specific disorder that the individual is suffering from. And following the Euthanasia Act, PID post-procedure is evaluated by a qualified coroner to ensure proper circumstances occurred. So some challenges and counterpoints to PAD. One note is irredeemability. So most psychiatric disorders are not in themselves fatal. So that brings the possibility that a patient with an untreatable mental illness may have decades to live, in which recovery or alternative treatment may occur. There's also the case of a reliable prognosis. So there's little known about the etiology of mental illnesses. So what is there to say surrounding a reliable prognosis with few reliable biomarkers, low diagnostic reliability, and difficulty in predicting the effectiveness of these treatments? There's also the patient's right to refusal. So while patients maintain this right, some argue that if a patient refuses certain treatments, can this really be classified as irredeemably suffering? And then finally, decision-making capacity, which is defined as the ability of an individual to make their own healthcare decisions. But many argue this becomes challenging to assess if a death wish is unduly influenced by said psychiatric disorder, or cognitive decisions are impaired by this sense of burdensomeness that many patients suffer from. Also, some individuals see this as a justified reason to exclude psychiatric suffering as a basis for PID, while others believe that this unjustified blanket ban for all patients takes out the patients that have the capacity to make a reliable request and subjects them to further suffering and cognitive distortion. So they kind of concluded that irrational health beliefs should be assessed. On the other hand, within this journal, retrospective elements were addressed, establishing that a patient does not need to necessarily assert their suffering will continue indefinitely, but rather that they have done everything to reasonably end their suffering. And this can be indicated by biological and psychological treatments, one recovery-oriented treatment, as well as substantial efforts to improve their social situation before their IPS or interpretive phenomenological analysis is established.
All right, so I put a quote, Provision 3 from the American Association of Nurses Code of Ethics state that the nurse establishes a trusting relationship and advocates for the rights, health, and safety of the recipients of nursing care. I felt like this fits the clinical implications because nurses must ensure that patients are fully protected ethically when discussing PAD as a course of treatment. This includes preventing coercion, ensuring access to care, and advocating for extensive mental health treatment before PAD is even considered an option. Mental health conditions can easily affect judgment, so nurses must observe mood, cognition, insight, and consistency of the patient's wishes for PAD. This is why the criteria for PAD due to a mental health condition is so subjective and why it's likely to not become widely practiced. And PAD cases require a collaboration of work between psychiatrists, ethic committees, social workers, and nurses to ensure comprehensive evaluation and make sure that the decision is appropriate for the patient specifically. And some things to specifically consider around this topic surrounding social justice, diversity, and equity are that marginalized groups and low-income patients sometimes have reduced access to effective treatment for mental health conditions. PAD decisions are at risk for being shaped by a lack of access to adequate care rather than a true personal autonomy. For example, a homeless individual or people experiencing trauma may seek out PAD due to suffering, not mental illness alone, which draws a blurry line. Moving forward with this practice, we can expect lots of legal requirements to go through with PAD, as well as the documentation of extensive previous treatment attempts. And then how can you tell who has the mental capacity to make this decision? There is like a widespread ethical debate on this topic. Obviously, patients have the right to make decisions about their treatment, including their end-of-life care. It's important to respect their autonomy, which means acknowledging that mental illness does not automatically eliminate one's decision-making ability. Ethical care requires listening to the patient's values, wishes, and reasoning. However, severe depression and other psychiatric disorders may impair a patient's judgment, insight, ability to weigh consequences, and their consistency of wishes. When mental illness significantly impacts these, the patient's ability to make informed PAD decision may be limited. Where do we draw the line? How do we distinguish between a patient's autonomous choice and a decision driven by symptoms of mental illness? Nurses need to balance respect for autonomy with the responsibility to protect vulnerable patients from decisions influenced by impaired judgment. This is still a highly debated topic and unlikely to be widely practiced. Before this project, most of us understood physician-assisted death in the context of terminal illness. We hadn't considered how nuanced it becomes when mental health disorders are involved. This topic is connected to the existing knowledge we have of psychiatric symptoms, mental health treatment, and the ANA Code of Ethics. Since the concept of PAD for mental health conditions is relatively new, the legality and ethics are still widely debated across countries and even states in the US. What we do know is that autonomy is essential, but an individual's capacity must be addressed before making any decisions. Healthcare disparities matter, and it's important to factor out any causes not related to detrimental mental health conditions in a patient's desire to pursue PAD for themselves. We know that nurses have a powerful voice in this process and are responsible for advocating for and exploring every other potential treatment route, ensuring that the client is fully informed and legally aware of PAD.